I think the biggest challenge that we have now is really how to sequence all of these therapies. And as we said to start, if you can cut them out, cut them out. But when you're at a point that you're having to use medical therapies, the biggest confusion we have now is we've got a whole mix of different things to use, and we're really not sure of the right sequencing for it and how to pick the right patient to sequence those treatments. In other words, say pancreatic neuroendocrine tumors, should we be using capecitabine and temozolomide before we should be using PRRT or vice versa? Those decisions really we don't have a lot of information on. We've had a lot of new drugs come in and not a lot of information on how exactly to take a patient through that entire treatment algorithm. I usually tell patients they're going to see every treatment that we can get to them, but what's the most optimal strategy for taking them 1, 2, 3, 4, and 5 through that regimen is not really known. So I think that's a big challenge. I think the intermediate high grade or the well-differentiated G3 component, which is kind of a new pathologic assessment of these tumors, is a challenging group. We don't know if chemotherapy serves those patients best, or if they're better served with things like PRRT, and there was certainly a spirited debate about that this morning. And I don't think that question's really answered, and that treatment needs to be individualized, and it often leaves a lot of hand-wringing for the oncologists. And I think the final biggest challenge is lung. I think lung has had a lot of disservice in a lot of different clinical trials, and so we're starting to see a lot more focus on lung neuroendocrine tumors as a specific entity, and hopefully get a little bit more data so we know what we're doing in that setting.